Yeah. As I got another rhyme, another rhythm for y'all to listen. I'm never quitting on my mission. I'ma roll with what I'm giving. Got some ambition, this new edition, filling positions. Looking at the void in myself and feeling what's missing. Better watch the way you going, better go in the right direction. In the moment you stressing, but you gon' be counting blessings. And I know that for certain. Keep on working, open curtains, haters swerving, cause they ain't ready for your final version. Whoa. I'm never gonna give up, fall down, I just gotta get up, yeah. Cause this is my road, lights, camera, action, I'm ready to go. I'm never gonna give up, fall down, I just gotta get up, hey.
You're listening to the Tom Ficklin Show on WNHH-LP 103.5 FM, your home for community radio.
Hey everyone, and really good morning and great morning. As we know, this past weekend, three religions celebrated really what it is to kind of have great mornings. And whether you're really a Christian or a Buddhist or agnostic or a Muslim or Jewish or Islamic, whatever you're, or just a person that believes in transformation, it's always good to get up. It's always good to get up. And we appreciate those of you that have gotten up to listen to this morning's show. And as you know, the shows are archived by virtue of Harry, our station manager in WNHH 103.5. So good welcome everybody, and great morning to all of you. Today's show topic is innovations in asthma treatment. I've devoted a number of shows to health, and folks will sometimes have not criticized me, but have been curious about why do I seem so laser-like focused on this health issue. Health is wealth. Health is wealth. If you want to be greedy, if you want to stay alive, if you want to help others, if you want to just beat up others, you got to be healthy to do whatever you want to do. And hopefully you'll use that health energy in a positive fashion. But health is wealth. There's no other topic on the planet right now, from my standpoint, in terms of what does health mean and how can we all become more healthy. So this morning, with innovations in asthma treatment, it's sad to say, but again, the part of the Tom Ficklin Show is sharing the truth, that the unvarnished truth, the transparent truth. And the New Haven area ranks high among other U.S. cities for rates of asthma and how it impacts a person's wellness. Today, the Yale Center for Asthma and Airways Disease is working to better understand how asthma develops in order to enhance the treatment of patients and ultimately develop new therapies and potential cures. So we have Dr. Jeffrey Chup. Dr. Chup is the professor of medicine at the Yale Center for Asthma and Airways Disease. We also have Reverend Dr. Leroy Perry Jr. with us, pastor of St. Stephen's AME Church, located here in the greater New Haven area, and Reverend Elvin Clayton, pastor of Walters Memorial AME Zion Church, located in the greater Bridgeport area. Both Reverend Clayton and Reverend Perry are cultural ambassadors to the Yale Clinical Research Program. And as I mentioned, Dr. Chup is the professor of medicine for the Yale Center for Asthma and Airways Disease. We're going to jump right in because May, I know it's April 18th, but May is around the corner. God willing, Allah willing, I guess spirit willing, but May is around the corner. So if we're blessed to kind of live in May, it's typically acknowledged as Asthma Awareness Month. Time when it's really a time when organizations, and in this case, our particular radio show, it's dedicated to the cause, to join together to create awareness and to better the lives of those living with this condition of asthma. According to the Asthma and Allergy Foundation of America, the month of May is chosen because it is usually the peak season for asthma flare-ups, and therefore the perfect time on April 18th for us to educate the public about the debilitating effects of asthma. And we're starting this conversation early. It's important, being proactive, taking charge of your health, not just putting your head in the sand. It's so important to kind of stay proactive and diligent about your particular health, your family's health, and if I could dare say, the world's health. Dr. Chup, good morning. How are you doing?
Great to be here, Tom.
Good. Let's jump right in, and we might repeat ourselves somewhat, but there's so many points that I want to emphasize and that I'm looking forward to you to share. So let's not be hesitant if we say things more than once throughout this conversation of the next 45 or so minutes. But let's begin. Give us, if you would, a little description of asthma and how it impacts a person's quality of life. But also, if I could ask you as a tag on, who gets asthma and why? So kind of, what is asthma, how it impacts a person's life, and who gets it, and why?
Well, That's a broad question, but I think a really important one for listeners to understand. Asthma is a chronic inflammatory disease that affects the airways of the lung. So those are the tubes that bring the air in. The pipes would be another way to think of it, that bring the air into your lungs to the airway tissue where the gas exchange occurs. And so when there's inflammation of those tubes, they get narrow and they get hyperreactive to the environment. And as such, it becomes difficult to breathe because patients have to do more work to pull that air in through these narrow tubes compared to a normal airway. Now, this can vary a lot. Another key thing of asthma is that it's variable. So patients may feel fine a lot of the time, even though there's inflammation there. But when they have an attack, those tubes may acutely narrow because there's muscle around them that goes into spasm. And they may require treatment with a rescue inhaler, or they may need to go to the hospital to be treated with more potent medications. Now, most of asthma is allergic. So most of the time what patients are experiencing is an abnormal reaction and inflammation to things that are in the environment that most people don't have a reaction to. And that's what we call allergic asthma. About 85% of patients with asthma have allergic asthma. That's really one of the reasons why we have May as Asthma Month, because all the allergens out there are popping, as we know, with pollens all over the cars and things like that in May. This is springtime, and that's when the allergy season really starts after winter, and that's why there's a high rate of asthma attacks. We don't know all of the reasons why patients get asthma and who the risk factors, all the risk factors, but I can tell you this. It's a combination of environmental exposures and genetic risk. So, for example, if you're born to a parent who has asthma or allergies, we know that that risk is probably about 25% that the offspring is going to get asthma because they've inherited some genetic risk factors for developing asthma. There are potentially other types of risks things. There's this thing called the hygiene hypothesis, that if you're not appropriately exposed to the environment early in life, if you're too clean, like our society has become to infants, and that we wash them all the time and keep them extra clean, they don't get used to the environment. And so they have a increased risk to develop asthma later in life, because as they get exposed to the environment, they start to react to it abnormally.
Before I go to, because there's this suggestion on the street, and you read kind of general literature that talks about the disproportionate impact on Black and Hispanic people in terms of asthma. But before I go there, I just wanted to kind of clarify. We also hear this term episodes or exacerbations, and you alluded to it a little bit in terms of the staging of the inflammation. But when we talk about the terms episodes or exacerbations, what does that connote?
Yeah, that's a great question. And I think that we do, as physicians, use these terms sometimes thinking that patients automatically understand what they mean. So I think it's really valuable to go over it for a minute or two. Exacerbation is another term for that, is a flare or attack. They all mean similar things. And they can occur for a few minutes or last for days or weeks, depending on the severity of the attack. Basically, it's a combination of that inflammation I described of the tubes, but also of the increased reactivity to the tubes, of the muscle around the tubes going into spasm upon an acute exposure. So, for example, someone who has asthma who walks into a room where somebody else has been smoking, or somebody who's wearing very strong perfume, might acutely have an attack because their airways are hyperreactive and they narrow very suddenly and quickly. And that patient may need to take a rescue inhaler, albuterol, to relax the spasm so that they can breathe again. Somebody who has a virus, say a respiratory virus, such as COVID, might get inflammation in their airways that is much worse than a normal person. That can increase the inflammation, and the muscles go into spasm more slowly over time, over days, potentially weeks, and that person may have a lot of inflammation and mucus production that needs to be treated with antibiotics and the rescue medications to keep their airways open so that they can breathe. And
we're going to talk about obviously clinical trials in your center, because we're just not, this show is not just designed to share somber information, but also to lift up some hope and talk about how people are devoting energies and medical insights to kind of, if not solving, alleviating or limiting the impact of asthma. But before Reverend Perry and Reverend Clayton, before I come to you, I just wanted to follow up with one more question with in terms of this stage with Dr. Chope, in terms of asthma and Black and Hispanic people. We've done a number of shows talking about the social determinants of health and whether racism is a medical condition or a public health crisis. But can you just talk to us a little bit about why? Again, it might be from a hypothesis standpoint, but again, you're working on hypothesis and exploring various scenarios. Well, why Black people might have the highest rate of asthma from a death standpoint, and Black and Hispanic people having the greatest incident?
Well, I think we are pretty confident that there's multiple reasons for this. And some of them have to do with genetics, and even the actual receptors in the airway maybe are different based on an individual's genetic background, and they may respond to the medications differently or put patients at risk of more hyper reactivity than people without these genetic polymorphisms. And these abnormalities, these mutations, may be more common in people of Black descent compared to other races. There's also, of course, socioeconomic reasons. For example, just in New Haven, we have highways, two large highways that are moving 91 and 95 that have where there's more exhaust and particulate matter, so the environment can be different there, and that can the socioeconomics of where people live in our community can have an impact. And related to this, of course, I think is our systemic kind of racism issues in our society, and how this has kind of led to this kind of culture and where there are disadvantaged situations for people in our Black community that we have to continually be working on as physicians to make sure that patients are treated the same regardless of race in our hospitals and in our healthcare systems. So all of these things have an impact, I think, on these outcomes and access to care that are things that we continually work on as part of the healthcare community.
We're going to drill down a little bit more on our let's say our offensive strategy rather than our defensive strategy in a second, in terms of your research, et cetera. But Reverend Perry and Reverend Clayton, I just wondered, you gentlemen are thoughtful people, and people might say, why do I always continually try to salute your diligence for each show that you're on? Because I mean it. You guys are thoughtful. You're diligent. You're in the struggle. You are the struggle. So as you hear Dr. Shub speak, there's some thoughts that you have about the prevalence of asthma and how do we see it impacting our community? Who would like to go first?
I would. I lived in Harlem for 20 years, between 155th Street and Washington Heights area. And they had a high amount of members of that community that had asthma. So one of the things that they did, and I didn't understand it when they did it, but they had someone out with a meter testing the air quality for weeks at a time just to see how that might impact the community with regards to asthma. It wasn't until recently, however, when I was taking the community health worker certification course, where we were given this example of a young girl who went to get her medicine for asthma. Her doctors had changed. And she just said, I just want you to give me the medicine to take care of my asthma. And he said, but wait a minute, tell me something about yourself. Where do you live? What are the conditions? Do you have wet basements? Is there mold in your house? Are there rodents in your house? And come to find out, that was the case. So he proactively called the health department, and those things started to get corrected, and the asthma started to get corrected with this young individual. So in terms of social determinants of health, I'm wondering whether or not when doctors see asthma patients, is it the idea that we can just give them Dupixent or albuterol or something, but not really go back to look at what might be some of the environmental causes that could help alleviate this?
Reverend Clayton? Reverend Clayton, you're muted. Just if you could unmute yourself, that'd be great.
Good morning.
Thanks so much. I look forward to hearing from you. I can hear you better now.
Okay. Asthma is personal for me because 2 of the 5 children had asthma growing up. And, when we were going through our research, we know that 20 million people in this country have been diagnosed with asthma, and 9 million of those are children. And listening to the doctor this morning, at the time I was living in Plainville, and just less than a mile away is 84. And I'm wondering it with that part of the problem. I mean, we had good doctors. They were getting treatment, but it was a struggle, especially in the younger years. And at times it could have been very scary or even fatal, especially with my younger daughter. But this information is helpful, that just because of the highway running less than a mile from the house,
That's Route 84.
could have been one of the major reasons why. And that question was never raised, from the medical people at that time.
Clayton, did your children outgrow asthma?
I don't know if I used the word outgrow. I thought my son did. But, he lives in California now, and he came back to visit, and in the fall of the year, and he got very sick. So we don't know if it was asthma related or just because of the change of weather when he got sick. As far as I know, my daughter hasn't had an episode in her, she's still fairly young, her 20s. She doesn't have a problem. But both of them live in California.
A little bit of pollution out there in California as well.
Well, it's a lot of pollution in California, but
Dr. Chubby, you've heard Reverend Perry and Reverend Clayton discuss kind of the contextual and environmental issues. I just wondered, and Reverend Perry in particular talked about the treatment. He didn't use the term treatment options, but whether doctors in your profession are using treatment options that are comprehensive rather than just, perhaps just textbook targeted. So I guess wondered in terms of managing asthma or responding to attacks, I want to give you a chance to kind of address that issue as we kind of progress.
Yeah, I think these were really excellent points, and I think they kind of highlight some of the issues that we are challenged by in the clinic every day. I always like to say to my trainees that it's really important to start with the environment in taking care of a patient with asthma, because you can improve things in terms of their severity of disease is simply by finding out what is driving their flaring or their inflammation in their environment. So, as the Reverend said, looking at looking at their environment in their home environment. Is there mold in the basement? Are they allergic to certain types of insects that they're being exposed to, or mold? So we always do allergy testing of patients, and we always ask them about their environment to determine, do they have carpets? Do they have forced heat, forced air heat? All of these things can be cleaned and modified so that their severity becomes much less, and they may require very little medication. So just kind of reaching for a medication is not always is often not the right thing to do. Although that's of course what we're trained to do as doctors. So, it's very easy for us to move in that direction. We also look at and sometimes have to get involved with landlords, write letters. We have an occupational health department that we refer patients to at Yale, where they will really sometimes go and complain to an owner, a homeowner, a rental department, or even the to get the environment fixed to help the patient. We often don't cure the disease, but we can often make it much milder for patients so that they can work, they can go to school without having flares that really impact their quality of life and their ability to be employed or get educated. I think that in some situations, this is not always avoidable. Sometimes people have a really hard time changing their environment. They can't just move, to a new place, so they can't afford to have mold abated in their home, and so we do have to use more medication, because we can achieve, better control with some of these new novel medications by that reduce the inflammation and stop the flaring in patients, even if they are being exposed to the environment. So we take all these things into account, and our real goal ultimately is maximize quality of life for patients, and that is eliminating the need for systemic steroids and visits to the ER, or missed school or missed work, for all our patients.
And before we go, Dr. Chuck, to the center that you've developed, the Center for Asthma and Airways Disease, I guess wanted to just kind of circle back again to ask Reverend Perry and Reverend Clayton in terms of community and our role and communication with them. What's the best way to direct our information, our focus on reducing the impact of asthma? I know it's kind of a general, global, $24 billion question for you two, but you might have collected that amount in the collection plates yesterday and the day before, so you may be able to answer the question. But how do we direct this information and communicate with our communities to just take advantage of the disease, to take ownership of our health and to seize our health? Reverend Perry?
Go ahead, Clayton.
Reverend Clayton?
I would think that a good start is to communicate to the community that there is help available. That's number one. And asthma is very treatable. To get yourself started, it's treatable. Don't just suffer. And I do understand that the numbers that maybe 4 or 5% of African Americans and Hispanic go to the emergency room more than our white brothers and sisters, but maybe they don't have a pediatrician or whatever. But educate the people knowing that there there is help for them. The things that we've learned thus far, that the environment could be a problem. The flowers in your yard could be an issue. Just keep pushing the information. The one word is education, education, education about what's available for treatment and what you can do to make your life with asthma, or so you can live better with asthma.
I think, Tom, that people who have asthma, they get help. I mean, you know, it's the squeaky wheel. If your child has a breathing problem, you're going to take them somewhere to get help. The issue is more than that. The issue is systemic. How do we get to the levels of educating our people about environmental pollutions? How do we get our doctors to be more sensitive to Black and brown people in their environment? How do we get them to speak, to really help them to take charge of this information? And for us as pastors and ministers, it just seems to me this program that we do with you is one of the ways we do it. The other way is we have a newsletter and word of mouth, but we have to start making it a priority for us to take these topics to the people and not wait for the people to bring them to us, because that rarely happens. Folks do not want to talk about their medical issues. They don't, you know, that it's private and they're confused. They don't really understand them, and there's no one there to explain them. So having this program really helps a great deal to our community. I'm hopeful that others will contact Yale and look at some of the things that we're doing in terms of clinical research, but also, you know, with the superhighway we have now, everybody goes online when they find something, but everybody needs to know somebody that they can trust to share this information with.
Dr. Triplett, let's weigh in, because Reverend Clayton and Reverend Perry have talked about now they've referenced the name and the great work that you're doing. So share with us some of the work you're up to, and it's, I know that my description is kind of blasé, but it's very important work that you're doing at the Center for Asthma and Airways Disease. So tell the listeners a little bit about the program, opportunity to be involved with the clinical trials, and even some success stories if you're willing to share.
Sure.
So the floor is yours.
All right. Well, thanks so much for the call out. You know, I think we have been working on for the last 25 years, you know, when I came to Yale, on really building a program and a center that was connected to the community and was really a three-legged stool, with one leg being the care of patients in our community with asthma and airway disease. The second leg was doing what we call basic research or translational research to help determine the causes of asthma and to understand some of the mechanisms that drive the disease. Back then in the 1990s, there was this epidemic, or this surge in asthma case rates, as well as mortality rates were on the rise. They've plateaued now the last few years. And then the third leg of the stool was a place where patients could participate in clinical trials and cutting edge research that was being sponsored by industry, pharmaceutical companies, but also research that was sponsored by the National Institute of Health, and that we had been granted to do research and now clinical trials. So, you know, currently we have two big areas of research and opportunity for patients, and that is what we call a phenotyping protocol, or a way that patients with asthma can come to our center and be studied. They can get their lung function tested and some blood drawn, and they give an airway sample. They cough up a sample. It's all non-invasive, and when we do that, we're able to look at the molecules and mediators in their blood and in their genes, as well as their airway, to help us understand what type of asthma they have. What is subtype of inflammation? Because we now know that there's multiple subtypes, even though they may all seem to be driving the same symptoms, that there are different mechanisms that are driving every person's disease, and that we need to understand it better so that we can more precisely treat every patient. The other big opportunity we have is something that's called the PRECISE trial. This is a clinical trial that's sponsored by the National Institute of Health, National Heart, Lung, and Blood Institute. This trial is a trial of novel medications to treat patients with uncontrolled asthma. It's a 3-year-long study, and patients are moved from treatment to treatment. There's 5 or 6 different treatments, and they get tested to see which treatment might be the best for them, and then they go on that treatment, and if it works, they continue on the treatment, and if not, then they move to a different one. This is what we are trying to do. We move towards what we call precision medicine or personalized medicine in this trial, so that we can find the right patient, right treatment for every patient. And so it's an effort to move in that direction. Both of these large studies are, patients are compensated for their time and their effort for participating. And I think one of the nice things for patients is that they get to contribute to the research and participate, which a lot of people feel very good about. But they also get a lot of attention because they come in for visits with our research coordinators every month, and we go over their asthma medications very carefully. We make sure they understand how to use them. They get lung function testing. This is all done as part of the trial. So they kind of become have kind of VIP status in our research community, in our practice, because they are in the, come in frequently as part of the research trial.
Chubb, I have a question, Tom. Let me ask him this question.
Please,
so after 3 years, when the study is over and the individuals who are given particular medications or drugs, are they allowed to continue to get the drugs, or will they have to go pay for the drugs? How does that work?
Yeah, that's a fantastic question. And I think at this point, I don't know the exact answer. I can tell you that with industry-sponsored trials, many, not always, but much of the time when the trial ends, the patients have an opportunity to go into what they call an open label extension, where they do receive the drug for free for several years afterwards, so that the company can gather additional safety data, and even after the drug's approved. It doesn't last forever, but it often gives patients access to the medication before it's approved by the FDA. We've had many patients, benefit from that. And some of our success stories are individuals who've gone into a trial and received the medication and had just a life-changing improvement in their asthma severity. After 25 years, I have many stories like this, and then the patients were eager to continue on the drug after the study ended. Even patients that received placebo, as you know, many of these studies, to do it scientifically, some patients receive placebo or not, they don't receive the drug, and other patients receive the drug. And nobody knows what the patients are getting, because we have to do this in what we call a blinded manner. And after the study ends, patients are then told whether they were receiving the drug or not, and then they can be allowed to, if they're interested to go on the drug, if they receive placebo, they have that opportunity as well. I think this NHLBI study, the 3-year-long study, I'm hoping that this will be an option for patients and they'll be able to stay on this drug. They'll probably have to get it through their insurance, or if there is an open label opportunity, then they can enter into another trial where they get the drug there for free. And again, those patients are also compensated for their time when they participate in the open label extension as well as getting the drug.
You're currently recruiting, correct?
That's right.
And so share for someone that's listening how they might want to explore getting involved. Is there a particular website or telephone number?
Yeah,
What's the best way
well,
for them
so
to?
you know, the Yale Center for Clinical Investigation has a website for participating in clinical trials, and they can simply type in there, you know, I'm interested in participating in asthma clinical trials. If they are, they may receive emails or communications from our center periodically about participating in the clinical trial. And you know, if they want to use phone, they can go on the internet as well and look up Yale Center for Asthma and Airway Disease, or look up asthma Yale. Our clinic will pop up, and they can call the number on that website or send an email through that site and contact us that way as well. So there's multiple options there. I'll get a phone number for you in a second as well, so that
Dr. Chubb, what is the compensation?
well, it varies. You know, we do it usually by visit, but depending on the study, I don't want to give you exact numbers here, but I can tell you that it's usually, you know, if the patient continues in that study for 2 or 3 years, it's several $1,000s.
Oh.
Yeah.
Dr. Crump, I'm sorry.
Dr. Trump.
No
Whoa,
offense.
that's
no
a new
offense.
one.
No
Oh,
offense.
Lord. Oh, boy.
Pray for you. We'll pray for you.
I'm sorry, Doc.
That's okay. That's okay.
You mentioned the precise trial.
Yes.
And you talked about uncontrolled patients with asthma. Does that actually mean patients that have asthma that have without treatment, or does that mean something else?
Excellent question. So these are patients that are receiving treatments. So the standard treatments, inhalers, but they're generally still having symptoms despite those treatments. Now, we have a lot of criteria for that's what we call controlled versus uncontrolled disease. Now, we define control in various ways, but for patients, they should just understand that if they still require, they're still having exacerbations on inhaled therapies, then they're not controlled. If their lung function is low, despite being treated, they're not controlled. If they have to go to the hospital because they have a flare or exacerbation or attack of asthma, then that's not considered controlled. And so all of those criteria, if any of those, a patient has any of those criteria on medications that they take every day for asthma, then those patients are excellent candidates for our study. There's a lot of criteria. They may not ultimately get in, but what we do when we evaluate the patient at what we call a screening visit, that patient gets evaluated very carefully, and we determine if they can enter into the study. For example, if they're not taking their medications routinely as they should, as they're prescribed, that would be an issue. Patient needs to be compliant and be uncontrolled, you know, to get into our study.
We have about 12 or so more minutes. So if there's some things that is kind of burning on your mind that we haven't discussed, let's jump in.
I'm going to give you a phone number here, Tom, if I can interrupt you for just
absolutely.
a second.
I want you to repeat it
So,
also at the end.
Any patient who is interested in asthma research, they can call 203-785-7324.
Repeat that
That's
again.
a phone, and leave a message with their information on it, and we will call you back.
And repeat that if you would for us.
203-785-7324.
Right. So folks, let's just jump in. We have about 10 or so minutes. I was curious, Dr. Chubb, How does it feel to be a doctor and be working on something that, or do you agree that it's at some point in time we will find a cure? Have you guys given up hope that we will find a cure, or you still feel that that's perhaps 50 years down the road?
Well, I think it's going to be a number of decades, but I actually think that for the first time in the last few years, we've been able to see a potential to cure some patients, or at least achieve a remission to the point that they don't need medications. We have very potent targeted medications now, injectable drugs, some of which were mentioned, that we have done research with and now use every day in the clinic. We participated in the clinic trials, and these have really had a dramatic impact on blocking some of the molecules that are causing the asthmatic inflammatory response in the airways. We don't know yet how long you might need to be treated or what cocktail of these medications might be the perfect option, but we do know that their effects are so dramatic that we believe that if given to a patient over time and early enough in the course of their disease, that we might be able to achieve a cure. So I do think that it could happen in my lifetime, in our lifetimes, maybe within the next few decades.
Doctor, when you say a cure, excuse me, do you mean that they will have to get a shot once a year, or
Right.
maybe? Oh, okay, that's what you meant. Okay.
Well, no, I think that this is the definition that we are starting to talk about here. What do we mean when we say we don't really use the term cure, we use the term remission, because we're just learning or starting to think about what the opportunity is. So some people suggest that we might be able to achieve remission, which is the kind of patient you're talking about, who maybe gets a shot once a year or every few months or something like that. But other than that, they have no asthma symptoms.
Okay.
In others, it may be possible to achieve what we call a cure, where you actually are able to take the patient off of all medications and their disease does not return. We're not sure what's achievable here, or whether we're going to first work on getting patients into remission, and then we'll see if we can ultimately achieve a cure. These are definitions that we're just starting to develop now for this disease.
Reverend Perry, I see that look again on your face. Please share.
Yeah, can I just say, we're looking at medicine in terms of the chemical effects of medicine in terms of a cure. But earlier you mentioned something that had to do with like an autoimmunity, where people were exposed earlier as children and not, to some of these elements, and their bodies naturally build up the immunity that they needed. Is there a part of your research that deals with that aspect, or is it all drug related and chemical? And then are the drugs detrimental if you take them for a long period of time? Do they have any effect on the other health issues within an individual?
Yeah, well, I think that fantastic questions. I think that we know that, for example, obviously your immune system is very important. It's in the development of asthma, and that it's really an immune-mediated disease. And so, if we can alter your natural immune response, we can have an impact on the disease. Now, some of that has to do with it isn't necessarily boosting the immunity, but it may have a lot to do with the microbiome, and that is the bacteria that are living in your airways normally all the time. And in some individuals, this population or community of bacteria may get altered, and that has an impact on how your the inflammation that is naturally occurring in your airway all the time. So there's always this give and take between the bacteria that are present normally in your airway, like your gut, and your immune response to that. And so if you alter the bacteria, you may be able to dampen the inflammation. So one of the treatment arms in our NIH study, our National Institute of Health study, is a treatment that affects the bacterial populations in your lung and your gut. So definitely something to consider. The second question you had is, do the medications we use chronically alter your immune response? And the answer is yes. This is a big thing. The main treatment of asthma for the last several decades has been inhaled steroids. And we know that steroids alter your immune response and do have long-term effects on your immune system in your airway and have some side effects. And so that's why we continue to search for new and novel non-steroid based treatments for asthma.
You think probiotics and that kind of thing, are they helpful?
Well, that's what we're trying to answer right now with our study. So I think that they have a potential to have an impact on the disease. We don't know exactly which bacteria or what the right cocktail is yet, but I think that, again, this is a way to personalize or be more precise about how we treat every patient, because we're treating the inflammation with the steroids, but we're also altering the bacteria that are present. So probiotics, I think we may someday have a asthma probiotic cocktail that is designed for each patient to make sure you have the right population of bacteria in your airways.
So the Greek yogurt, try to eat the Greek yogurt at the moment, non-fat Greek yogurt at the moment.
Yeah, that's the best you can do right now.
How young is it in terms of the onset of asthma? How young can a person be?
Very young, within the first year of life, patients can develop asthma.
In the first year of life. Well, gentlemen and everyone, we have about 5 more minutes, so let's kind of brainstorm and maximize the time that remains. Any burning questions or thoughts there, or prayers that are on your mind?
Well, I wanted to know how young were your research clients? I mean, is there...
So our studies, I'm an adult pulmonologist, so generally we go down to age 18. There are studies, most of the medications are approved down to age 12, but the research and some of the centers that I could refer patients to if they wanted to participate down to age 12 in New York City, some of the centers that are involved with the NIH study, we could refer the patients there if they were interested. But at Yale in New Haven, it's mostly down to age 18.
One other question. How often do they have to come in for the testing or the...
Yeah. So I usually tell patients that, there's at the beginning of the study, there's a few visits that may take half a day or longer. But after the study, once you get approved to be part of the study, it goes on it's about half a day, once a month.
What's kept you? You mentioned it's been more than 2 decades that you've been committed your professional career to this topic. What's kept you really inspired and hopeful and dedicated to kind of persevering in this regard?
Well, one of my early interests was because my son developed asthma. I remember when I was training in lung disease, and I woke up and he was standing at the end of the bed at 3 a.m, and he was about 2 years old, and his nostrils were flaring and he was wheezing. And that's when I first realized I had a child with asthma. And fortunately, he's been relatively mild, but that kindled my interest in asthma as a trainee, and that's when I started doing research in the area. I think what's really kept me involved, there's two things. I think, first of all, the opportunity to do research at Yale has been unparalleled, really, and to pursue new knowledge in the area, and the system has supported us doing this, and the community as well has always been really engaging with us, and patients in the area of New Haven have always participated and enjoyed working with us, and that's just been incredibly personally rewarding. I love the patients that I get to work with. After so many years, I consider a lot of our many of them friends as well as patients. The other thing is, I've been fortunate to be part of this revolution in new knowledge and the genomics revolution, and also the development of these novel therapies that really dramatically improve patients' control. And so it's been incredibly rewarding to do that. And third is that it's really exciting to talk about it on radio shows like this, and give lectures to trainees, and talk around the country and the world about how to use these drugs effectively and what we need to do next to try to achieve what I like to call remission level control for patients.
Harry's going to play the music momentarily, so let's go ahead, Reverend Clayton.
I also understand that more women have asthma than men. Now, could that be related to makeup or that type of thing?
Well, yes, there is definitely a slightly higher rate of severe disease. It actually changes over your lifetime. Early in life, it's actually more commonly in boys, and then it shifts to women later in life. So adult onset disease is more commonly in women. There may be hormonal things and differences in the biology of women versus men that drive that shift over time. But certainly, some of my patients, not necessarily makeup, but ones who work in hairdressing, for example, there's a lot of volatile organic compounds, hairsprays and perfumes and things like that fumes related to nail polish and things like that definitely contributes to their severity. But again, it's always a challenge, because I want people to have a normal quality of life, and they can't necessarily quit their job. So, my job is to try to get them controlled so they can continue with their profession of choice.
Good job. Thank you so much.
Thank you.
We have to go. We got to bring you back. You were great. Reverend Clayton, Reverend Perry, good to see you guys. Happy belated Easter. Dr. Trump, thank you so much.
Thank you very much.
Thank you.
I know that for certain. Keep on working, open curtains, haters swerving, cause they ain't ready for your final version.
This is Harry Droz, and you're listening to WNHHLP 103.5 FM New Haven.
Let's camera action, I'm ready to go. I'm never gonna give up, fall down, I just gotta get up, hey. Yeah, this is my road.